Welcome to this talk on topical versus systemic NSAIDs, a guide to clinical practice. I'm Dr. Martin Johnson. I'm a GP with a long-standing interest in chronic pain. I'm also Vice President of the British Pain Society and also Clinical Lead for Chronic Pain for the Royal College of General Practitioners in the UK. As is required, please find on the screen my financial disclosures for this talk. Within this talk, I'm going to go through the history of NSAIDs and their mechanism of action. I will then turn to the differences and also similarities between the various types of NSAIDs and particularly compare systemic and topical formulations. Lastly, I will attempt to answer some questions that are raised about NSAIDs within the context of their use in clinical practice. So, for our first section, a brief introduction to NSAIDs. The history of anti-inflammatory medication dates back to the ancient Greeks, when Hippocrates recommended that willow bark should be chewed for relief of both pain and fever. In the 18th century, we saw the first clinical trial with willow bark for the relief of fever. In the 19th century, we saw the isolation of the active ingredient of the willow bark and subsequently the development of aspirin. Then, in the 20th century, many of our NSAIDs that we use today, for example ibuprofen, were developed, and also our understanding of their mode of action expanded, culminating in the COX-2 inhibitors. I would now like to describe a typical pain model. As with most pain models, we initially see cell damage occurring, which can be from a variety of different reasons, for example soft tissue trauma. After tissue damage, arachidonic acid is cleaved from the membrane phospholipids. Arachidonic acid is a key signaling molecule for pain transmission. Cyclooxygenase enzymes then catalyze its conversion into prostaglandins, which are a key mediator of the pain response. Finally, we see the pain pathway, where the nerve signals travel from the point of cell damage through the peripheral nerves, through the dorsal horn, and then the spinal column, finally ending up in the brain. It is important to realize two basic facts in the mechanism of pain treatment. Firstly, the COX enzymes are involved in many homeostatic, pathophysiological and adaptive functions in the body. Secondly, NSAIDs are inhibitors of the COX enzymes. This inhibition reduces prostaglandin production, thus resulting in an anti-inflammatory and analgesic effect. In particular, COX-2 is thought to be an important enzyme for pain and inflammation, and many agents target COX-2 specifically. So, what are the key roles of the COX enzymes in the body? From our perspective, the key function of the COX enzymes is the conversion of arachidonic acid into prostaglandins. COX-1 is expressed in all tissues and is involved predominantly in the homeostatic or housekeeping functions of the body, such as protecting the stomach wall, reducing acid secretion, and also inducing platelet aggregation. COX-2 is generally undetectable in most tissues within the body until either pain or fever response is initiated. Production in inflamed tissue increases by up to 80-fold and leads to prostaglandin production that mediates pain, fever, and finally inflammation. Prostaglandins increase pain and inflammation in four key ways. Firstly, increasing microvascular permeability. Secondly, increasing blood flow. Then they increase arterial dilation. And finally, they sensitize neurons to the sensory stimuli. The first three stages lead to both redness and edema, characteristic of the inflammation seen after tissue damage. The fourth characteristic leads to sensitivity and pain around the affected area, which is particularly seen in neuropathic pain and often called either hypoanalgesia or allodynia. It is important that we understand the differences between NSAIDs. NSAIDs can be categorized into four main groups. Those that inhibit COX-1 and COX-2, but with very little selectivity, such as ibuprofen and diclofenac. Secondly, there's those that inhibit COX-2 with moderate sensitivity, such as celecoxib. Those that inhibit COX-2 with high sensitivity, and finally those that are weak inhibitors of both COX-1 and COX-2. Selectivity between COX-1 and COX-2 inhibition is an important differentiator for systemic NSAIDs. Diclofenac has moderate COX-2 selectivity, whereas ibuprofen is slightly selective for COX-1. Other drugs, such as rovacoxib, are highly selective COX-2 inhibitors. It should be noted that selectivity for COX-2 is not the only consideration when differentiating between NSAIDs. Overall inhibitory potencies should also be considered. As you can see from this diagram, diclofenac appears to have the greatest potency of NSAIDs when tested in vitro, i.e. the lower the number, the higher the potency. In terms of side effects, relative selectivity comparisons between COX-1 and COX-2 show that COX-1 inhibition is a key factor in gastrointestinal risk. Overall, in this comparison, diclofenac and ibuprofen appear to have the lowest risk of gastrointestinal toxicity. Now, I will compare systemic and topical NSAIDs. Systemic NSAIDs are available in tablet, capsule, injectable and suppository forms, and topical NSAIDs are available as gels, creams, sprays, emugels, ointments and patches. Of course, different NSAID formulations are tailored for different uses. NSAIDs have been used for a substantial period of time, and their use is well documented. Some patients may prefer a familiar route of administration. Tablets and capsules offer pain relief and anti-inflammatory action for a wide range of common medical conditions. Plus, the antipyretic action is an additional benefit. For many years, I used to carry injectable diclofenac as an emergency painkiller within my medical bag, for example, for renal colic. It was much safer than using high doses of opiates. For many patients, they will turn to purchasing over-the-counter or OTC NSAIDs. Oral NSAIDs are used for short-term for the treatment of acute, mild to moderate pain, for example, arthritis of the knee, headaches, and many other uses. Although they are commonly used in osteoarthritis, several official international guidelines recommend topical NSAIDs due to their targeted effect. The use of topical treatments for pain are also well established in history. They are classified into three groups as seen on your screen: local anesthetics, counter-irritants, and also the NSAIDs themselves. Topical NSAIDs provide an additional option in patients for whom oral treatment remain inadequate or are contraindicated. This builds upon the natural ways of alleviating pain, for example, rubbing and massaging, but also adds a pharmacologically active analgesic to increase pain relief further. The various preparations can also be combined in some formulations with either cooling or heating mechanisms. A range of NSAIDs are available as topical agents, for example, ibuprofen and diclofenac. They are supplied in numerous formulations offering different properties. They can differ, amongst other things, in their skin penetration and also their moisturizing effect. With a wide range of products available, therefore patient preference is therefore enhanced. Gel formulations are often considered the most effective with increased skin penetration, plus they offer a more acceptable, less greasy application. The one negative aspect of gels is their alcohol content, which in some people can be skin drying. Cream formulations are also available. Again, this will depend on patient preference about which one you may use. They may be considered more moisturizing or negatively some more greasy, but overall they are less effective at penetrating the skin. This chart shows the relative safety profiles between the various different types of topical NSAIDs, but overall they are generally well tolerated. As you can see, a variety of different local skin reactions are the most common adverse events. Key advantages of topical NSAIDs are that they offer a targeted action, low systemic exposure, and thus reduced risk of drug interactions, and so are generally well tolerated. Improved tolerability and ease of use may lead to improved patient adherence. This long-term safety study of topical diclofenac in nearly 600 patients looked at data from patients less than 65 years of age and over 65 years of age, and then compared the rate of adverse events in both groups. Topical diclofenac was shown to have similar low levels of important AE rates in both of the age groups, for example, cardiovascular and GI. This demonstrates that diclofenac's potential in an older population in which oral NSAIDs may be contraindicated or cause safety concerns. In this study, the AE rate between oral ibuprofen and topical diclofenac was compared in the use of finger osteoarthritis. The topical diclofenac was associated with a reduction in overall and severe AEs when compared to oral ibuprofen. There was also a reduced rate of discontinuation due to AEs and drug-related AEs with a topical formulation. In the same study as the previous diagram, it was shown that oral NSAIDs can be associated with the well-known GI events. However, this risk was reduced with topical formulations. Key contraindications for diclofenac gels are generally very few. The following are taken from the official datasheet: hypersensitivity to diclofenac or to any of the excipients contained in the gel, patients in whom attacks of asthma, urticaria or acute rhinitis are precipitated by acetyl salicylic acid or other NSAIDs, and also the last trimester of pregnancy. The datasheet gives further special warnings for the use of diclofenac gels, including they contain propylene glycol, which may cause mild localized skin irritation in some people. Their use should be discontinued if a skin rash develops after applying the product. And finally, they can be used with non-occlusive bandages, but should not be used with an airtight occlusive dressing. In comparison, there are some important contraindications for the use of systemic NSAIDs, including severe heart failure, because it may impair the renal function, liver fibrosis, cirrhosis, or acute liver failure, as there is a risk of variceal bleeding, hepatorenal syndrome, or encephalopathy, severe hepatic impairment, current treatment for gastrointestinal bleeding, symptomatic peptic ulcer, GI perforation, or obstruction. They are also contraindicated in those with a history of hypersensitivity or severe allergic reaction to an NSAID. I will return to the mention of asthma later to expand on this. There are some key populations in which NSAIDs should be used with special caution. Firstly, the elderly. There is an increased risk of serious adverse effects such as GI bleeding and perforation, which may be fatal. A history of peptic ulceration or those at high risk of GI adverse effects. Inflammatory bowel disease, which may increase the risk of or cause exacerbation of ulcerative colitis or Crohn's disease. Hepatitis or cholestasis, with an increased risk of GI bleeding and also fluid retention. In renal impairment, avoid it if possible, but sodium water retention may occur, leading to deterioration in renal function and possibly full renal failure. Heart failure or hypertension, because it may impair renal function again. And finally, women trying to conceive, because it may impair the female fertility. In all of these populations, the prescriber must exercise specific clinical judgment about when to use or not to use the products, and of course, increase monitoring of the patient when using them. Now I will move on to several frequently asked questions regarding the use of systemic and topical NSAIDs and their use in clinical practice. The first section compares the different molecules and formulations. Question: can systemic NSAIDs safely be used to treat stomach pain? My own stomach used to get a knot in it with concern when a patient used to tell me this. They used to say, "Oh, I've used my anti-inflammatory for a stomach pain." Particularly since the use of NSAIDs to relieve stomach pains is controversial and concerning because of the association with GI events. However, of course, in some diagnoses, such as a soft tissue injury to the abdominal wall, NSAIDs are suitable. The next question is one I said I would return to earlier in the presentation. Can systemic NSAIDs be used for patients with asthma? Many times I've heard clinicians and pharmacists say that a patient cannot have an NSAID simply because they have asthma. This is not strictly true. Some NSAIDs are contraindicated only if a patient has previously shown hypersensitivity reaction in response to NSAIDs, for example, asthma, rhinitis, angioedema, or urticaria. Indeed, NICE state that unless NSAIDs clearly cause severe exacerbations, they should be considered as an appropriate treatment and patients should not be denied the benefits of an NSAID. How do systemic NSAIDs and COX-2 inhibitors compare in terms of adverse GI events? In a meta-analysis of 26 randomized controlled trials, the combination of a traditional NSAID plus a proton pump inhibitor affords greater risk reduction for dyspepsia than COX-2 inhibitors compared to traditional NSAIDs alone. This has led to bodies such as NICE advising that routine prescribing of an NSAID and PPI together, especially if the NSAID is for anything other than a very short use or the patient is at risk of GI problems. Does the product formulation affect the efficacy of topical NSAIDs? As with oral NSAIDs, topical formulations vary in their efficacy, and it goes without saying that not all topical NSAIDs are the same. In fact, a recent 2017 Cochrane review confirmed that diclofenac Emugel has the lowest number needed to treat value of the topical NSAIDs tested. This means that fewer patients need to be treated before one patient gets substantial pain relief. What is the benefit of topical NSAIDs that include penetration permeation enhancers? Skin penetration is an important factor in the efficacy of topical NSAIDs. The permeation enhancer in Voltaren 12-hour substantially increases drug delivery through the skin to the underlying target by up to a 3-fold factor. How does the systemic absorption of different topical NSAIDs compare? Systemic exposure varies slightly amongst topical NSAIDs as demonstrated by this slide. However, in all cases this is minimal and substantially less than with topical NSAIDs compared with oral formulations. The next section looks at how we can target NSAIDs optimally. Are there particular types of pain where NSAIDs are less useful? One of the most disabling types of pain that a patient can experience is neuropathic pain. NSAIDs are not helpful in the treatment or relief of neuropathic pain. Guidelines rarely mention them as treatment options. Nevertheless, many physicians prescribe them for such conditions, though personally I've never seen any benefit. Indeed, a 2015 Cochrane review by Professor Andrew Moore from Oxford examined the clinical effectiveness of NSAIDs in neuropathic pain. While more evidence would be welcome, they concluded that there is no robust evidence to support their use for the treatment of neuropathic pain. What is the optimal duration of treatment with a topical NSAID and an oral NSAID, and how long can they be used for? Duration of use of oral and topical NSAIDs varies dependent on the patient need and also the underlying pathology. And of course, prescribed and over-the-counter NSAIDs, even of the same molecule, have different recommendations. It is now normal practice that a recommendation for the use of oral NSAIDs should be limited to the shortest duration possible to control symptoms. Topical NSAIDs should not be used for more than 14 or 21 days, again dependent on the condition, unless recommended by a physician. Are the systemic risks associated with the use of oral NSAIDs also a concern with topical NSAIDs? This study was performed in 10 healthy volunteers to assess the absorption of diclofenac after treatment with diclofenac diethylamine 1.16 gel for 8 days. Participants received a single application of 5 grams of gel on days 1 and days 8 and 2 applications per day on days 2 to 7. On day 1, the levels of unchanged diclofenac increased until 24 hours of application in all but 2 of the subjects. On day 8, a residual amount of diclofenac was detected before application of the drug, and the concentration of diclofenac in the plasma was maintained at a higher level than that on day 1 for all subjects. The MHRA in the UK have stated that due to their low systemic exposure, it is unlikely that topical NSAIDs are associated with significant systemic risks. What are the key factors that would dictate your choice of a systemic or a topical NSAID for the treatment of a patient's pain? To my mind, and possibly in the following order, the key factors guiding my choice of either an oral or a topical NSAID include safety, patient preference, clinical guidelines, and also physician preference. Also, the location of the pain could also be a relevant factor to consider. Unfortunately, I've seen many patients without a regular carer prescribed a topical NSAID when they cannot reach the area to be treated, for example, muscular mid-thoracic pain. Finally, and in summary, we've seen that NSAIDs have been around in clinical practice for a long time. The mode of action, via inhibiting COX-2 and subsequent reduction of prostaglandin production, is well established. Several different types and classes of NSAIDs exist, with diclofenac being amongst the most potent. We've also seen that several different types and formulations of NSAIDs are available, and it is proven that they have reduced the risk of side effects compared to oral NSAIDs. The final choice of an NSAID will be made with the help of the pharmacist or prescriber, depending on other comorbidities and concomitant medications that a patient may be taking, and also the area of the body to be treated. Most importantly, it gives the patients another choice, thus helping treatment adherence and ultimately the relief of their symptoms. Thank you.